Hello and welcome to the Neurocritical Care Society podcast. I'm your host, Nick Morris from the University of Maryland and Shock Trauma Hospital. And today I have a really exciting podcast that I'm looking forward to. It's part of our Hot Topics series, and we'll be talking about the critical care management of patients after cardiac arrest, a scientific statement from the American Heart Association and Neurocritical Care Society, with two of the authors of that statement. Today I have with me Dr. Karen Hirsch and Dr. Teresa May. Karen, would you mind starting off by introducing yourselves to the listeners?
Thank you so much for having me. It's a pleasure to be here. I'm Karen Hirsch. I'm an associate professor of neurology and neurosurgery at Stanford University and the co-chair of the statement.
Great. And Teresa?
Yeah, thanks for having me as well. My name is Teresa May, and I'm a medical and neurointensivist at Maine Medical Center and assistant professor of medicine at Tufts University.
All right. Well, thank you both for joining me today. And first of all, congratulations on this work. I imagine this took a long time and you poured through a lot of literature and had a lot of conversations, and that this was not an easy task. So congratulations on completing it. And I also want to say, I think this is huge for us as a society to have really this joint statement with the AHA, where we are putting out kind of guidance. We won't say guidelines, and we'll get into that later, but we're reviewing post-cardiac arrest care, which I don't think maybe widely is the full breadth of it is maybe recognized as part of neurocritical care. And certainly when I started neurocritical care, no one was asking me about MAP goals and ventilation goals. So I think it's shown in some ways how far our field has come. So congratulations, and we're really excited to review this. Karen, maybe we can start off by talking a little bit about, what prompted this scientific statement? Where did it come from? We have guidelines from the AHA on post-cardiac arrest care. So what is a scientific statement, and how does that differ from guidelines?
Yeah, thank you. I think it's an important topic. The first thing I would say, even taking a step back, is that Dr. Romer Giaccaden, who was the co-chair, certainly gets all the credit for the conceptualization of this. I think he had previously been very active at American Heart Association and working on guidelines. And what he and I had been discussing at the genesis of this was that the guidelines are super important and they're super helpful. But what a guideline does is it takes existing available literature and it evaluates the body of literature and it translates it into guideline recommendations. But the good parts of that are that we use very, generally speaking, high quality literature. But the downside to guidelines is that we're very constrained by the literature, and the recommendations in a guideline are constrained by what the literature shows. And so you'll see actually in the methodology and in the introduction to this, we actually talk through the genesis of this statement, which was that we felt that there was a huge opportunity to provide additional guidance and expert opinion to help people take care of these patients. There's emerging evidence that the post-arrest care and what happens in the critical care setting really is so fundamentally important. I think we all know this, but I think, it's good to have evidence of that, and really wanted to codify, some of these question marks in management for these patients, where maybe the literature either doesn't address a topic or perhaps, it tells us something but doesn't tell the full story. And so that was why we conceptually decided to do this project. And so at American Heart, they have scientific statements, which is basically an opportunity to address a topic where you are not as constrained by the guideline sort of level of evidence and et cetera, but you're also not making recommendations, right? So I want to be clear that these are expert opinion statements, but they are not quote unquote guideline level recommendations. And so that's a big, important difference or differentiator between this statement and then the guidelines. And then last but not least, I'll just touch on very briefly methodologically how we approach this, which was getting a large and diverse group of authors from, when I say diverse, I mean geographically diverse, career stage diverse, but also practicing, like practice setting, professional career. We had respiratory therapists, we had pharmacists, And we decided the scope, we decided the topics that we wanted to address. We did literature reviews and discussed and came to consensus statements, which you can see in the document. But again, there's not systematic review level literature. There's not, meta-analyses necessarily. So I just want to be very clear because I do think it's a confusing point of how this differs from a guideline.
Great. I think that's very helpful. Let's dig into what you just said a little bit more. So I think one of the really important things you mentioned is getting a multidisciplinary and diverse group together. And can you kind of walk us through, as the co-chair here, how did you actually find these people? I mean, did you put out a call? Is this the case of, you identify people how does it work?
Yeah, I will definitely give credit to NCS and AHA as the sponsoring institutions for this. We started essentially just brainstorming, people we know, people in the field. We sort of, I guess, did like snowball recruiting, if you will, where we we're like, oh, we need a pharmacist with this expertise. Hey, friends in cardiac arrest world, who's a good pharmacist who works in this area. And had a much larger list because there's many people who aren't on the statement who could have been and who are excellent. And then really worked hard with the sponsoring societies to think critically and make sure that we're not, like you said, just calling up our friends and people we know, but to make sure that we're getting input from the societies and from other people who are in the field. To ensure that we have diverse representation. And then we reviewed potential authors with both societies, looked at conflicts of interest, et cetera, and eventually were able to get it down to the current working group and author list.
Great. And then take us to, once you get this group of people together, and it is a really impressive group with a lot of expertise. I'm guessing you probably met over Zoom and hit some of these topic areas that we'll get into later, and broke up the work. But how do you go from that to actually coming up with the statements? And can you walk us through the process?
Sure. A couple of things I would say. One thing I didn't emphasize that Teresa and I had talked about before is we have junior members on the group who are not authors. But we had some people who were just coming out of fellowship, who, time has passed now, and they're both assistant professors, but Melissa Vogelsong and Alexis Steinberg. And so I think that was also a nice thing that the societies let us do, was have junior people come and learn from this process, which is something I think is super important and that we should all think about doing when we have projects. But to answer your actual question, this started in the summer of 2019, and we basically developed scope and had many meetings over Zoom and assigned topic leads, et cetera. People would go out and do the literature reviews, to talk amongst their small groups and bring back suggestions and statements. And then we met in Vancouver at the annual meeting in 2019. And we had made great progress. But I will be the first person to take responsibility for what happened next, which is COVID. And the world sort of, went side. I'm not taking responsibility.
Yeah, so it was your fault.
Not taking responsibility for the COVID pandemic, but taking responsibility for, basically, we have a bunch of intensivists and ED physicians and, people whose lives got very, very busy. So things got quite delayed. But really moving this forward, what we did was try to codify what we had discussed in person in 2019. And then really by sort of 2021 had a near final draft. But at that point, did a re-review of literature. So you will see literature in here, post 2019. But I will acknowledge it was not done systematically for every single topic. Where we had new high impact studies coming out that we knew about, we definitely made sure to reevaluate the literature and reincorporate them before the final publication.
Great. And then can you tell listeners a little bit about the modified Delphi process that was used to kind of gain consensus or not for the statements? How did that work?
Sure. So each topic lead or small group would come, do the literature and then do the literature review and then present preliminarily their statements. Don't let me say guideline, but their statement. And then we would discuss it as a group and iterate on the language and then vote. We voted anonymously. by electronic voting. And if we had not achieved 80% consensus at that point, we would discuss again and do the same process again. And so we had up to 3 rounds of that to achieve 80% consensus on a statement. And if we did not achieve 80% consensus on a statement at that point, that statement was retired. It's still in there, and you can see the statements, especially around, I think ICP targets is a good one that we might discuss, where consensus could not be achieved.
Great. Let's talk a little bit about scope. You mentioned that that was one of the first things you did is address scope. And I think maybe some readers will be surprised that there were some things that were left out of the scope of this, some things we think a lot about. Maybe I think you can explain why, but there's reasons that they were left out. And those were primarily, I think, targeted temperature management and cerebral edema. Is that correct? And
yes, I mean, there's probably a lot that was left out, but those 2 were very intentionally left out.
Yeah. And can you just explain and make explicit for people why you all decided to leave those out? Because I think some of us might have opened that, read the manuscript for the first time, wanting to, fast forward to the area about temperature management, for instance, but there's really nothing there. So why did you leave that out?
Yep, I think for a couple of reasons. First, if there's any area where we have lots of randomized control trials and relatively better quality evidence, it's probably in the temperature management space. Now, by no means does that mean that we've figured out what to do with temperature management, and by no means does that mean there's a clear answer in my mind about temperature management, but it simply is an area that is addressed robustly in many different guidelines already, and where there is more literature around it. And so we didn't feel that contributing expert opinion on top of existing guidelines would necessarily add anything, and in fact would probably just confuse people more. So that was the first thing. And then cerebral edema, as you know, Neurocritical Care Society has a guideline out about management of cerebral edema. We know it's not specific to post-cardiac arrest patients, and that, you could make an argument that there's still a significant gap here that could benefit from being addressed. But because there is an existing guideline about cerebral edema management from one of our, co-sponsoring societies, we did not want to get into the sort of weeds and details on that as well.
Okay, well, fair enough. We'll let you off the hook on that. I think there is a lot of controversy about both evaluation and management of cerebral edema in this patient population, which is super interesting. But in a way, you sort of get there because you talk about ICP, don't you? And that in some ways is maybe a surrogate for that discussion about edema.
Maybe.
Some ways.
Maybe.
Maybe we can talk a little bit more about that as we get into the content. So Teresa, can you kind of walk us through some of the major statements around ICP monitoring and treatment of edema or elevated ICP? Because I think this is, in my own experience, has gotten a lot of attention in the scientific statement. And, it's not something that I think many centers are actually doing. So I guess one of the questions is, after you talk us through a little bit, is this something we should be doing? Should patients routinely have ICP monitored, at least according to the writing group?
Yeah, so that's a great question. And, even dating back to 2019, I remember these discussions pretty well. I think the nice thing about this statement, that it's not a guideline, is that we had some flexibility in the statements that we could make, as experts in the field. And I think we know that cerebral edema and elevated ICP happen, and we know the natural history of elevated ICP and cardiac arrest. And I think the sentiment around the cerebral monitoring statements are that there's an opportunity, if you have the expertise, to do the measurements. And if you're able to do the measurements either invasively or non-invasively, and understanding the limitations of both, that would be reasonable in a select group of patients to change the natural history of what we know would otherwise happen. Karen, do you have anything to add?
Agree. I think the other thing I would say is, we did achieve consensus on this, but again, just like Teresa said, the goal was not to say everyone should put an ICP monitor in every post-cardiac arrest patient. but simply to say that, in centers that have expertise and in patients that are potentially salvageable, this can help guide management. And I remember, I forget what the counterpoint was, but I remember one of the authors saying, this doesn't seem right that we're going to say, like, you can put monitors in people's brains, but we can't, agree on a blood pressure target or whatever it was. And so I think it just gets back to the sort of spirit of this, which is, there's not there's no guideline level evidence, and we don't know exactly who's going to benefit from ICP monitoring yet at this point. But it's simply to say there's opportunity here. There's really significant opportunity to apply multimodal monitoring to these patients, to think more about brain resuscitation and how we guide brain resuscitation. And so really wanted to push the envelope a little bit and making statements about this so that people feel like within their practice, they can do it. It's not to say every place gets an ICP, every patient gets an ICP monitor post-arrest. That obviously is not the intent of what we're trying to say.
Yeah. And I think I'll add, after the publication of this, we at my center developed a protocol for which patients might benefit from an intracranial monitor and how we would manage that.
Yeah, no, that's really interesting, is sort of coming up with some, not a national guideline, but maybe some at least institutional guidelines or institutional protocols to determine, if this is something you want to do, and if so, who would you do it in? Karen, I think you mentioned that there were some statements that you didn't agree on, and some of them were actually in this field in there. I can read a couple of them off here. So one was that agreement could not be achieved on the optimal timing and duration of invasive ICP monitoring in patients after cardiac arrest. And the other was agreement could not be achieved on a target ICP goals in patients after cardiac arrest. So I think maybe there's some inherent tension that you were getting at in this idea that we could all agree that we should consider ICP monitoring, but we can't agree on what the target is, when it should go in and when it should come out. And this is, I think it's fair, right? I would say that's fair. That's where we are with the science right now. Do you have anything to add to that?
I think just some of the nuances behind the discussion were exactly what you alluded to, which is like, we really just don't know. We have numbers that we know if they're above a certain threshold, that's associated with worse outcome, but that's not necessarily normative data in cardiac arrest. So we had a lot of discussion of, can we extrapolate TBI data to this patient population? And ultimately that was the driver, I think, of why we couldn't achieve consensus, is people just felt like almost like anything we said would be arbitrary. And so, you could argue some of our statements are perhaps arbitrary. I would push back and say they're maybe a little arbitrary, but not completely arbitrary. But I think the group felt like anything we said around this would be just so arbitrary, because we really just don't have data around any of this. And it's the other thing we want to do when we write statements is open up the field for research and support, give people something they can point to say, look, this is a gap and we need additional data here. And so this was an opportunity for us to say, this is an area that needs more work and more research.
Great. Well, one content area where there is some more emerging evidence is in MAP goals after cardiac arrest. And, I think it's something we argue about all the time at our institution is what should the MAP goal be? And there is now some, let's say, inconsistency maybe between what the guidelines say and sort of the scientific statement here. Can you, Teresa, can you talk us through that a little bit and kind of give us the reasoning for why this group of experts came up with something that, some people might read and say, well, that's not in the guidelines. I don't know if I agree with that.
Yeah,
I'm putting you on the spot here.
That's a great question. No, it's a fair question. I think it has to do with the flexibility of having a group of experts interpret the data in a way that doesn't necessarily have to go in the flow sheet that we make when we make guidelines, as far as grading the quality of evidence. So I think it's a little more nuanced approach where there's some flexibility to interpret those studies a little bit differently. The patient populations that they included are not necessarily reflective of all the populations that we see, especially here in the United States. There may be some subgroups that might benefit from a higher versus lower strategy. The target that it's a little bit higher is overall safe for most patients, but probably not all patients. So I think we're getting into this again, allowing for some flexibility based on the interpretation of the data that hopefully will drive more research and eventually will sort of get us to a better place and maybe help us identify patients that might, benefit from a higher or lower temperature, or sorry, not temperature, blood pressure.
Always have temperature on the mind.
Right.
I'm just wondering if you can give the listeners some insight into like, what was the group like in this discussion about MAP goals? I mean, was there a wide consensus or was there real debate on this? Because I think it would just be really interesting to know, kind of to be in the room and hear the conversation.
Yeah, I think there was real debate, and it did go back and forth quite a bit. We had cardiologists on the writing group who have run some of the clinical trials, not in MAP targets, but in other cardiac areas of cardiac arrest. We had a lot of neurologists and ED folks and, pharmacists and nurses. So we really had everybody's opinion, I think, reflected in this. And I believe it did go several iterations of voting to get to consensus. There was a great deal of discussion about, we had gotten into this triage section a little bit later down in the statement about triaging patients to a higher or lower MAP target. And, the idea was even floated out, should we suggest or pitch, a triage strategy for more aggressive cardiac management versus more aggressive neurologic management based on risk, not prognostication, but risk. And eventually we decided that there wasn't enough data to support, going that far, maybe for a future statement. That would be a really interesting thing to do. But yeah, a lot of different opinions in the room, but eventually consensus was made.
Got it. I wanted to bring up the triage statement because I thought it's so interesting, because there's sort of, allusions in different content areas that maybe for certain patients this would make sense and maybe not for all patients. But then it's sort of, I guess a nice interpretation would be you all gave freedom to the reader to decide who those patients are. Is that fair? Meaning not a lot of prescriptive advice about who should have more aggressive MAP goals or more invasive monitoring, et cetera.
Yeah, I think the sentiment was that this, one size fits all protocol for post-cardiac arrest management in the ICU is something that we probably should be moving away from. And I think it hopefully gets the reader thinking that, the one protocol that doesn't have flexibility for, EEG monitoring treatments, temperature, not necessarily temperature in this statement, but blood pressure, ventilation targets, neuro treatments, multimodality monitoring, et cetera. You should, stand at the bedside and look at the patient and decide to do what's best with them. And I think that's where, within the writing group, there's a lot of years of expertise and a lot of years of taking care of patient after patient with cardiac arrest. And that's where some of these ideas are coming from, rather than, the cut and dry literature.
Sure. Can I ask you all to sort of step outside the writing group for a second? And if you mentioned at Maine Medical, you came up with sort of some guidance on maybe who should have some invasive monitoring. What are some of the things that you're looking at your institution that you think are important to make that determination?
Yeah, so I'll say that we started with looking at our own data, and we went back. We're collect our own data systematically as part of our practice. So we looked at patients who had early cerebral edema and their trajectory, and tried to draw a line between how bad that cerebral edema needed to be on initial CT scan, background EEG, sometimes BIS1 monitoring, and other clinical parameters to try to capture patients who were at risk of a neurologic death or progression to brain death, but not sick enough that we might not be able to intervene in a timely fashion.
Got it. Karen, can I ask you the same question? How about at Stanford? What are some of the things that you all look at in kind of the early stages of care that might dictate whether you aim for a higher MAP goal or maybe an ICP monitor or whatever the more aggressive version might be?
Yeah, I think I would call attention to figure 1 in the statement, which I think is maybe for neurointensivists seems sort of obvious of the complex interplay between heart and lung and brain physiology. But that was essentially, I think, what the heart of the statement was to say that you can't manage post cardiac arrest brain injury in a vacuum, that you have to manage it in sort of concert with everything else that's going on below the neck, because they're also, the physiology and pathophysiology is so intimately intertwined, and thinking about how these impact each other. And just like Teresa was saying, the cardiologists in the group were saying, if you have a, blown out LV, it doesn't make any sense to be arguing for a higher MAP, and everyone can get behind that. So I think, again, this concept of one size fits all is not, it's just not reasonable, right? And we need to do sort of personalized medicine and think about the patient in front of us. So I think for us, we're still figuring this out. Like everybody, I think in general, what our approach is that if we have someone who post arrest is relatively stable from a cardiac standpoint, we will try to aim for a higher perfusion and a higher MAP target, as long as there's no evidence of myocardial dysfunction or pulmonary edema. But we understand that this is dynamic and needs to be reevaluated. I really think this is where neuromonitoring comes in, and whether it's invasive or non-invasive, but really helping us understand how brain perfusion and brain oxygenation is, being titrated in an individual patient with systemic organ dysfunction is a sort of a key tenet of this. But I would say at Stanford, like it's not like we have all the answers. We're still sorting this out. And I will just say, like, our neurosurgeons thus far have not been interested in placing invasive monitors, but it's an ongoing discussion. And I think as additional literature comes out from sites showing that invasive monitoring helps maybe not change outcome, but at least guide management, then we can continue to have ongoing conversations about this.
Yeah, I think that's such an important point, is that many of us don't place our own monitors. I know Teresa's group has maybe the great advantage of being able to place their own monitors and decide when these go in and don't. But the rest of us, we collaborate closely with our neurosurgical colleagues. And so we might make all the statements we want, but we're going to need some assistance in the actual procedural aspect of delivering this care. So getting them on board, I think, is a whole nother part of this project of personalized care. Cool. Well, let's shift gears a little bit and talk about something that I know Teresa's done a lot of work in, which is maybe sedation and analgesia. Teresa, I know you've published quite a few papers looking at various sedation practices, and what did the group have to say about sedation post-arrest?
Yeah, so the group had a few statements on sedation and analgesia after arrest. I think these were all fairly straightforward, or none of them might have been, surprising. We know that sedation and analgesia can accumulate and interfere with prognostication after cardiac arrest. So that has to be taken into context. There can also be, like Karen said, heart and lung interactions and neuro interactions with sedation and analgesia management. So I think the sentiment was to provide short-acting sedative and analgesic medications, with the goal of providing comfort for patients. In patients who have neuromuscular blockade, we need to take that into context and make sure those patients are appropriately sedated. With cardiac arrest and other neurologic injury, it's difficult to measure depths of sedation, light, moderate, deep, etc. So I think we shied away from a lot of that verbiage in this statement, and more left with like a conceptual template of what types of medications to use and how to consider, the duration of action and potential accumulation and things like that.
Sure. And I know you've thought a lot about this topic, so I'm just interested in getting your opinion. Kind of since the publication of TTM2, I think a lot of hospitals may have changed their cooling practices. What do you see kind of moving forward in the realm of sedation? It seems like maybe we're going to see less deep sedation and less paralysis if people aren't cooling or are using a different depth of cooling. What do you think?
I think, regardless of the depth of sedation, temperature control, depending on the patient. Patients still shiver, even at 36, even at 37.5. Patients may shiver a little bit more at the higher temperatures, depending on how you look at the data or who you talk to, or how you conceptualize that. So I think as long as we're using temperature management, regardless of the depth, neuromuscular blockade is still going to be a piece of the toolkit. The continuous versus intermittent neuromuscular blockade continues to be a topic that we don't have the right answer for. Perhaps at the higher temperatures, it's not required to have patients on continuous paralytic, but it hasn't gone away, and I don't see the use of neuromuscular blockade going away and the need for sedation. Duration of temperature management is also something that's a new topic, and hopefully we'll be learning more about in the coming years. So whether or not, some patients could get away with shorter durations of temperature, and therefore need less overall sedation or have less sedation burden in their ICU stay, it sort of remains to be seen.
Yeah, that's a great point. I'm not sure if you saw this pilot study that came out, but I've been meaning to talk to you about it because I know you think a lot about the thaw study, where they sort of intermittently tried to wake people up during the cooling period, and actually successfully were able to kind of wake some people up and get them extubated. And that's something I would never have considered doing before I read that study. And I think this study was published after you all had sort of finished your review of the data. But yeah, what do you think about this idea of sort of doing little check-in exams at different points during the potentially hypothermic period even?
Yeah, so I think in the right patient population, that might be reasonable. Obviously, this isn't something that we discussed during the statement preparations, that doesn't reflect the opinions of the group. For patients who we sort of triage as having a moderate or light brain injury, either by their background EEG, the characteristics of their arrest, the exam when they arrive, et cetera. Those patients, it might be reasonable to have a shorter duration. We, in practice, occasionally see patients wake up during TTM and are sort of left with what to do with that. Do you sedate them and can, finish your protocol, or do you allow them to wake up? But I like the idea, and I like the thought of doing this in a systematic way, like a pilot, and then maybe an eventual trial.
Great. Karen, I think another area where there's been some new emerging data since the statement was released was in ventilation. And so I think the TAME trial probably came out after you all had finished your statement. Can you maybe give your thoughts on, well, one, maybe share what the statement was with the listeners, and then give your thoughts of sort of how you might integrate the TAME trial into what the group came together and said.
Yeah, I think there's been, sort of a challenge has been obviously keeping up with the literature. Like, it takes a long time from the time you meet and write to until something comes out. And so that's the one thing I'd say is that to people, sometimes I see, like, in the angry, blogosphere, what X was formerly known as Twitter, be like, how could they not include this? Like, oh my gosh, it was a year and a half, whatever. It takes a long time from writing to publication. So certainly, as soon as statements are published, there's other literature out there that was not included, and just acknowledging that. So yeah, I think, similar to everything else we've been talking about, the TAME trial, the box trial, all of these other, sort of important randomized trials are coming out with approaches to oxygenation and ventilation and blood pressure, and sort of basic physiologic cardiopulmonary management for cardiac arrest patients. And for, a variety of reasons, they're not showing very significant difference in the two arms in each study. And we can interpret that literature in many different ways, but there's a couple of things I would say, which is, again, first of all, I think a one-size-fits-all approach to cardiac arrest research probably isn't going to tell us the nuances of this. The second thing I would say is just there's patients who have a worse injury and probably need manipulation by the ICU team. And then there's patients who probably need us to just leave them alone and support them while their own physiology recovers. This is completely, my own opinion now and not borne out by any literature, but I think sometimes there's patients who benefit from interventions and sometimes there's patients who benefit from us just stepping back and supporting them while their own body recovers. And figuring out who those patients are is hard. So I think in general, Tame told us that targeting different CO2 targets broadly is not going to change outcome. But in general, I think we try to aim for normocapnia, we try to aim for normoxia, we try to aim for normotension. That said, when my team writes in an ICU note, avoid hypotension, maintain normoxia, I'm like, yes, every ICU doctor in the world knows these things, right? So I think just figuring out which patients are going to benefit from manipulations to a higher or lower physiologic target versus which patients, we just need to sort of keep in this very, sweet range, sweet spot is hard to figure out. And I still think that, yes, the trials are going to say we don't have guideline level evidence to recommend a single number target for broad patient populations, but we need to just think about the underlying physiology of our individual patients.
Okay, so maybe we can kind of take a step back now and look at the big picture. And I think you've already hit on some of these points, but one, I'm wondering in that angry blogosphere or perhaps in more civil arenas, what feedback have you gotten on the statement and how are people receiving it?
Well, I'm not on social media intentionally, so I don't know what's out there. But I think I have gotten a lot of questions about many of the topics we talked about. Specifically, I think blood pressure and ICP monitoring are the two areas where I've gotten a lot of emails and questions. The other one I would say is the EEG section and monitoring, which we haven't delved into, but just a lot of controversy, I think, and not controversy, but discussion and questions about how do we manage the ictal interictal continuum and who should be monitored and when. And I think, again, we did the best. I think that we arrived in a reasonable place on this statement. But it's not to say that these are all the answers. I think people are right to question the methodology of how we got to these statements, especially the ones I just alluded to, which are perhaps a little more controversial, and really just think about it themselves and think, I would put it back on people to say, come to the table and help us do the research and help contribute to this because, we need help. We need people. We need smart people and engaged people to help us contribute to the literature and answer all of these questions that still remain. But I think overall, it's had a good reaction. I think the biggest concerns is just making sure people understand the difference between a guideline and a scientific statement and understand what our objectives were in making these statements.
Great. Teresa, I'm wondering, having been part of this writing group and going through all this literature with everyone and kind of getting to share conversations with so many experts, how has your approach to the post-cardiac arrest patient changed?
Yeah, that's a great question. I think, obviously I've learned a lot through this experience. And I think the biggest benefit to me personally was networking and getting to know the rest of the writing group, some of whom I've known quite well, but many who I didn't. And that diversity of opinion, the way that I think the nice thing about this statement is it kind of reads like an intensivist thinks. It goes through the systems and talks about, the nuances of all the different things. But my, perspective as, a pulmonary critical care neurointensivist person is very different from the cardiology group, and the nuances that the nurses brought to the table and the pharmacist, is really important. And it helps me have sort of a broader appreciation for, everybody's experience and the nuances of taking care of patients like this.
Excellent. And then Karen, kind of to end this segment, maybe you can highlight for you, what are the big priorities going forward and how we can do better than this, and where I think we're getting towards having maybe a more precise way to look at individual patients and decide what to do. But what are your sort of takeaways and research prioritizations after reading the statement?
Yeah, I think there's still a lot of work to be done. I think one of the things when you're in training is like you think you know what you're doing and that you know how to manage patients, and then you delve into the literature and you get older and hopefully a little wiser, and you're like, oh wow, there's so much of this that's unsettled. There's so much of this that we really don't, or don't know what the quote unquote right thing to do is for this individual patient. So I think almost literally anything in this statement is ripe for research. I think it's in the statement because there's not good, high quality literature to support a guideline level statement around it. But certainly I'm biased, but I think the neurologic management of patients post arrest, we know that neurologic injury is driving outcome. We know that this is the biggest driver of both morbidity and mortality post arrest is the brain injury. So being intentional about research that is going to address how we resuscitate the brain and how we treat an injured brain after cardiac arrest broadly is really going to, I think, move the needle on our outcomes for this patient population.
Great. Yeah, I would add that I think this is from my mentor and someone that Teresa knows well, Neeraj Pajadia. He always talks about how we have grading scales for most of our major illnesses, right? We know what a Hun-Hess 4 subarachnoid hemorrhage looks like and how that management changes from a Hun-Hess 1. And we have the ICH score, which we don't want to use for prognostication, but we kind of know that means something about severity and what to do with it. And we don't really have that score. I mean, people have developed scores for sure, but it's not kind of universal parlance in post-cardiac arrest care. And I think until we start having some way to determine, as you said, who do we just let, their own body kind of just provide supportive care and let them heal? And who do we need to be really aggressive in both our monitoring and in our therapeutic interventions? It's going to be hard moving forward. And I think we're going to see a lot of neutral trials. And I would hope maybe in the future, the prioritization is on trying to distinguish these patients early on so that we can enrich our trials with patients who are more likely to benefit from any intervention. But that's why I get to have the host of the podcast and add my 2 cents. You two are the experts. I want to thank you so much for joining us. Any last thoughts for the listeners?
I was just going to say, we agree since we're co-investigators on Precise Cap, which is seeking to do just that. But we won't talk about our own research today. But yeah, agree completely. And thank you for having us to cover this important topic, Teresa.
Yeah, agree. Thank you very much. This was fun.
Awesome. Well, thank you two so much. I learned a lot. I'll be very careful with my language when I talk about a guideline versus a scientific statement, and I will never recommend, but I might say suggest. And so thanks for joining us on the Neurocritical Care Society podcast. I'm your host, Nick Morris. This podcast can be found wherever you get your podcasts, and continuing medical education credits are available for select episodes. Thanks for joining us.